Good evening, everybody, and welcome all those out in Facebook land to the Martin County Town Hall, the Opioid Crisis at Martin County Town Hall. My name is Micah Robbins, and I am the Director of Special Projects for the Palm Beach County Substance Awareness Coalition, Behavioral Health Coalition. I'm also part of the Drug and Alcohol Advisory Committee here in Martin County and a resident of Hobe Sound. So this issue is near and dear to my heart, not only professionally, but personally, and certainly where I live as well. We have an esteemed group of experts here tonight to discuss an ongoing crisis, not only here, but in many counties and states and cities across our country. I'll go right around the table here so we can introduce, and then we're going to have, I'll explain the format and the questions we're going to have tonight. So, starting immediately to my left, and for those that are out there, you'll be able to see folks when they speak. Dr. Aneshka Marshall from Tykes and Teens, an expert in adolescent and family therapy and counseling, especially in the areas of behavioral health and substance use. She is also a teen leader and expert with adolescent issues. Welcome, Dr. Marshall.
Thank you.
Robin Tupper not only is an advocate, she is on the board of the Recovery Community Organization, Palm Beach County Hub. She's part of the Recovery Awareness Partnership, and she's also a parent, a nurse, and also a parent of loss. She has lost a child to the opioid crisis and is a very special member of our community. Thank you for being here. Chris Camel, Captain Chris Camel, the chief from Martin County Fire Rescue, an expert in the field, also someone who sees this issue on a daily basis, is on the scene and is also working with not only parents but families and the community at large on an overgrowing crisis, and we welcome you to this program. To my right, Dr. Jay Kuchera, Vision Health Services. He is an anesthesiologist. He is an expert in not only pain management, but also an expert in medically assisted treatment modalities, including buprenorphine, naloxone, and other areas. He's a nationally known speaker, contributes regularly to many different areas in this field. He's also a member of this community, and it's a pleasure to bring him to the stage. And Captain Bill Dowdy, I almost said Dr. Bill Dowdy, from Martin County Sheriff's Office. Now, the Martin County Sheriff's Office, of course, is the law enforcement leader here in Martin County, and not only is it a leader in this area, they're also looking at some innovative approaches to helping those in need with substance use disorders and behavioral health needs. And it's a pleasure to have you here this evening. So, tonight's format. The panel has been given the questions for the evening. I have the questions as well. We're going to have this as more of a discussion. I'm going to be offering the questions in various areas of need and areas of interest around this topic. I'm going to direct a question at first. However, anybody in the group is more than welcome to give feedback on that question as well. Every question has many aspects to it because we have many different perspectives this evening. Also, for those watching live at home on Facebook Live, feel free to bring questions to the table. You just bring them into the, type them into the comment section, and we'll try to work them into the flow of the conversation as best as we can. We're going to work very hard to keep this to 1 hour. We appreciate everybody's time on this very, very important topic. So thank you all for being here. Thank you all out in Facebook land, and thanks for all the members of the community to be involved in this. All right. As I bring up our first question of the evening, and Bill, I'll direct this towards you, but again, please, everybody, feel free to have some feedback as well. Our Sheriff William Snyder, has discussed the increase in opioid-related deaths as a crisis here in Martin County. From your unique perspective, what elements of the issue have you encountered, and describe the situation, the situations that you have encountered related to the crisis?
You know, the sheriff has described this as a public health crisis, and that's in fact what it is. You know, the elements that we've encountered, we respond to the calls where we've had overdoses. We have the families who are dealing with the overdose child or other family member, whether it be a spouse or whoever's in the house with them. Our deputies are seeing, you know, the distraught family members. They're seeing the terror in the eyes as if somebody has found their loved one on the floor. This is a public health crisis, and we've noticed here, especially in the last 5 months during the pandemic, that it's growing, and it's growing quickly. And it's something that the sheriff has recognized. We have a mental and behavioral health unit, and we're trying to move forward and work with the community and try and stop some of the occurrences that we're seeing.
Chief Campbell, as you are seeing the calls as well, not only law enforcement but public safety, is there a certain area of the population that you're seeing is more affected than others? And also, when we talk about increase, do you have any particular numbers that you're seeing that are increasing?
Absolutely. I have not noticed. This is a widespread issue across every neighborhood. It is not specific to one area or socioeconomical class. It's everywhere, and it's ever present. The numbers we're seeing compared to last year to this date, we're more than 25% higher than we were last year at this point. A lot of repeat patients. Of 172, I think we've had thus far this year, we only had, I think, 65 unique patients that split up that many overdoses that we've dealt with thus far. So it's widespread, and it's a repeat issue.
And when you say repeat issue, are you utilizing naloxone or other reversal drugs to reverse these overdoses?
Absolutely. All of our paramedics are fully trained in that, and we give IV naloxone starting at 0.4 milligrams initially until we regain respirations. And the success rate's very good. Narcan works very well. It's a great medication. But it all depends on how far they've been down or how long they've been down before they get that medication to see whether or not they recover.
And Dr. Kuchera, for the audience at home that may not understand what naloxone may be and its other counterparts, could you give a brief description of what those medications do and how they're so effective in this crisis?
Yeah, naloxone's a drug, a medication that's been in use in the operating room for many, many years. We use it clinically to reverse the effect of opioid or narcotic, I call it opioid-based anesthesia. It's used in the community for overdose situations. And so it's a molecule, it looks, if you look at the molecule, it looks like a kind of like a morphine molecule with some little bells and whistles on it, but it absolutely has zero opioid effect whatsoever. So it doesn't cause any pain relief at all. It doesn't cause respiratory depression. In fact, it reverses it. So what it does is it comes into those receptors in the brain where the opioid molecule, like if it's heroin or fentanyl or whatever it is, oxycodone is sitting in there and causing respiratory depression. The naloxone will come in there, and those molecules, they take turns. They come on and off the receptor. Naloxone has a high affinity. It really likes to sit in there, and it will come in there and displace or occupy that receptor, and it has no activity. So it's like if you were trying to use a key to unlock a door, and that door was causing respiratory arrest, and the naloxone would be like putting a key in there and kind of breaking it off. You can't get in there. So I don't know if that explains it or not. And by the way, a lot of people have a misconception that if you have naloxone, if you're carrying, it's also called Narcan or Evzio, the two popular forms. But I tell my people all the time, if you see anybody on the ground, spray them or inject them. And they say, well, can I hurt people? And if you're not opioid dependent, if you're just a non-opioid dependent individual, you can give massive doses of this medication and not cause any trouble at all. It doesn't have any effect unless you're opioid dependent, and then it causes a withdrawal syndrome.
And Chief Campbell, a question for you too. When you talk about your utilization of that, it's been an effective strategy. Do you have an idea of how many dosage levels you've actually administered this past year?
We've treated 171 patients thus far this year. Of that, about 65 of those were unique patients. Otherwise, it was repeat patients. Most doses people get are 1-2 doses, but I did not research exactly how many doses we used. I just researched the number of patients. But rarely do we have to give more than 2 doses to get somebody to recover.
And the Sheriff's Office is at 44 usages themselves this year. If you compare to last year, we were at 58 for the whole year. So we're already at 44, and that is just one incident doesn't mean that there wasn't two dosages given.
That's just an incident of reversal. And that's one of the questions that's come up from a lot of folks, too, with the increasing strength of the analogs, fentanyl, carfentanil, and other analogs, opiate analogs, that with the increased strength that the dosages, for example, 1 to 2 dosages, we're hearing stories of 3 to 4 or more to get reversal. Have you encountered any of those issues?
We have. We've had instances where the deputies have actually deployed Narcan 2 or 3 times. Fire rescues arrived on scene. They've done, what their needed dosages, and it has become pretty popular. I won't say popular. It's become routine that we see there's more than one dose needed.
And that's certainly an environmental change we're going to see as we go forward.
It is.
And one of the things I wanted to ask too, and I'm going to direct this to Dr. Marshall, again, as we're trying to educate the community here, as we're talking about opioid use disorder, this may seem a bit nebulous to people in the community. Could you just give a brief overview of what opiate use disorder is? And then with Dr. Marshall and Robin, I'd like to talk about maybe some of the things families can be looking for, or people in the community can be looking for as warning signs.
Sure. So at this time, our diagnostic statistical manual classifies all use disorders from mild all the way to severe. And essentially, there's 11 total symptoms that you are looking for. So without having to just recite all the symptoms, but people can look those up on drugs.gov. But what those are going to translate to and what they're going to appear as is that they're going to seem like their personality is going to be different. Their emotional stability and ability to manage their emotions is going to be different. You're going to see changes in their relationships, so that may be increased conflicts with various people in their world. They might withdraw from particular family members. They might change their social circle. Other things that you're going to see is problems start to arise in various areas where they have to exhume particular responsibilities, whether that's with parenting. So, for example, not being able to pick up a child from school. Additionally, maybe from work, having trouble keeping a job, getting reprimanded at the workplace. Physically, you might see some symptoms where the person just generally is not looking very well or is frequently ill. I think in a nutshell, those are some of the main things that are most observable.
And Robin, again, and please describe what you choose. I know this is not easy, but you've been through this with your family. What were some of the things that you either witnessed and then, or if you could please just describe some of the process that your family went through with opiates as it affected your family?
My son battled for 14 years before we lost him. So started at a young age, and then that process changed through the years. We went into the legal system because again, as he changed drugs that he needed to use in order to attain that next high, those kind of things, monies would need to be changing or increasing, and so if he wasn't, the reality of the situation is the disease brings lying, stealing, manipulating, destruction of family and loved ones and people that are supporting, all because, as I used to say, I had 2 children in one. I had the child that I gave birth to, and I have the child that suffered from substance use disorder. That child that I gave birth to was always the person that I loved, and the child that, my son Nick told me many, many times that when he wanted to use, that it wasn't anything about loving family, nothing like that. It was all about the drug. It's an obsession. The brain takes over, and he would do anything that he could to manipulate either myself or somebody else to gain access to that drug. And that's something that is often misunderstood or not understood by loved ones or family members out there, because people want to say, if you love me, why don't you just stop? You can see the destruction that's happening in the family, you can see the destruction in your life, etc. And they just don't have that ability a lot of times. It takes a village to be able to make that happen for them. And it happens over and over and over again. Unfortunately, somebody going to treatment one time is not the norm. That's the rarity. I remember the first time we sat in a family group with our son when he was in treatment, and they turned around and said, well, you need to be prepared for the next time, and we're looking at each other like, what are you talking about? This isn't going to be fixed. And it wasn't. It wasn't. Yeah, that's, it's a very hard disease, and it's multifaceted. There's most often a mental health component to it, and it takes a long time and a lot of work. It's like any other kind of disease. It's something that they are going to have to learn to manage for the rest of their life.
And Robin, thank you for that. And was there a progression? Was there a starting point or a certain substance that your son started with and then it progressed to opiates?
Yeah, he started smoking pot, just casually, never really a drinker. He was of the time when Roxy's or the Blues were very popular here in Martin County. And then from there, because of the cost, and my son went through the South Florida Shuffle and did the manipulating, went to the doctor shopping. He was brokered throughout Florida. And, then he eventually, went up to, heroin, fentanyl, those kind of things, ultimately, passed from carfentanil and heroin.
And you mentioned carfentanil. That is an analog of a synthetic opiate, much like fentanyl. And I'm going to ask Dr. Kuchera again to kind of explain some of these things. Dr. Kuchera is actually a wealth of information. My apologies, Dr. Kuchera, for going back to you on the science of this. But if you could give a brief explanation, too, of sort of this origin. And, we're not talking heroin, per se, anymore a lot in these communities, but really analogs, opiate analogs. And could you explain how that works? Because when people hear words like fentanyl, they hear words like carfentanil, and again, it find meaning in that. And we're talking exponential levels of power over morphine or heroin. Could you just give us a brief explanation of the analogs?
Yeah, so, one of the first opioids around we had opium and then codeine and morphine, and progressively as we manipulated the molecule, we came up with stronger and stronger medications. So there's a group of opioids, the first ones that are based around the first opioids that came out of the poppy plant. And then scientists came up with the idea that they could manufacture a molecule that really got in there and stuck to that receptor in the brain much more efficiently. And honestly, the molecules don't look anywhere near the same if you were to look at pictures of them. But anyway, so fentanyl was really one of the first of that particular class, and then they started tweaking that molecule and coming up with progressively more potent molecules. So fentanyl is in carfentanil, and there's probably over 20, 25 analogs right now, or more. Honestly, I haven't checked in about a year, but I think the driver for them and why they're around is because of pressure on the supply of heroin and shifting sources and the international trade, kind of figured out that if you have a molecule that's 5,000 or, times more powerful or 4,000, whatever the potency, you can ship it. They're shipping very, very powerful, we call that a synthetic opioid. So a synthetic opioid is fentanyl and whatever. morphine is the original opioid, and the semi-synthetic is like hydrocodone, oxycodone. Anyway, you can put a lot of doses of carfentanil into just a little tiny, like the anhydrous pack that was in like urine test strips or whatever, glucose, they were shipping it inside of that, and you could get massive. It's so easy right now to send large doses, through the web and whatnot, CD cases, and it's, but it's gotten to be now so 70-80% of identifications in the community are fentanyl. It's everywhere now. Fentanyl analogs. I say fentanyl, but really there's so many different analogs right now that's just become a generic term for all the synthetics, just to say fentanyl. Right. Carfentanil is one of the absolute worst. Shocked to see it manufactured in a pier, because it was not even approved for use in humans. It was a veterinary medicine, and for use in large animals, rhinoceros, elephants, and there's even more potent ones out there. Fluoroomafentanil, it's about 18,000 times stronger than morphine. So so there's almost no end.
And that's one of the issues that we're discussing with communities, is that even folks that have been in recovery and then may find themselves in a relapse situation, the environment they're going back out into is far more dangerous than it was. You can almost go month to month to month, and it becomes more and more dangerous. Captain Dowdy, from the interdiction side, law enforcement side, are you seeing increased traffic of these issues? And I'll add to that, some of our data is showing that many other substances are being cut infused with fentanyl. So cocaine is making an appearance, but it's being cut with fentanyl. Even marijuana is being laced with fentanyl. So it's like a ubiquitous additive at this point. Are you seeing sort of these changes in interdiction and from the law enforcement perspective?
We are, and not just on the county level. They're seeing it on the state level. They're seeing it on the national level. They're seeing it on the international level. Not all of the fentanyl is coming from just one location in the state of Florida. It is moving up and down our interstates. It's moving, as the doctor said, in the strangest ways and the strangest patterns. People are finding ways, because it is such a potent drug that it doesn't take much. So they're moving small amounts to large amounts. You're seeing it mixed with the marijuana, the cocaine, and different substances. It's the new wonder drug on the street. Everybody's trying to come up with the next new cross-match or cross-match street drug, the wonder drug. And we're seeing it. We're constantly coming across things, especially our narcotics agents are constantly coming across things where they're reaching out to our state labs and our local doctors saying, hey, this is what I have, or this is what I think I have. And it leads us off on another trail that, it's leading us here when we originally, hey, we thought we were just getting fentanyl. Well, it's mixed with this. It's, being designed to be used with this. And it's confusing. And it's not like the early 2000s where we're dealing with just strictly the Roxys and the oxycodones, and we knew what we had, and this drug is leading us everywhere.
And when you say everywhere, is there a way to describe it? So if someone is seeing it, I mean, you're listening to Dr. Kuchera, I mean, it's almost anything.
No, honestly, some users know what it is. You see some of our overdoses where, and I'll mention those numbers in just a second, they don't realize what they have. The dealers themselves, I think, are aware. The vast majority of them are aware, but the end user, they're looking for that object that's to get them high, to relieve whatever stresses it is. They're not focused on what that actual item contains. So it's hard to give a description of what they all look like today, because what I tell you today may not be what we find 20 minutes from now. Real quick, this time last year, July 1st, 2019, we had 14 overdose deaths in Martin County. Today, for July 1st, 2020, we're at 28. We've doubled. So that's the crisis we're facing.
And that actually leads to my next question. Looking at resources, Can we describe some of the current initiatives that are happening in this county, both fire rescue, law enforcement, and then I'm going to certainly discuss this with Dr. Kuchera as well, some of the medically assisted interventions that are out there as well. But systemically, what are some of the things that are happening because of these increases, some of the strategies that are in place right now?
If I understand the question correctly, the resources that we're using, I mean, our resources are starting with the patrol deputy that's responding to the call. And a lot of times that resource leads to him needing his backup in case there is another Narcan usage needing. Constantly, these calls ultimately lead to fire rescue. The vast majority of them, fire rescue comes on scene, and unfortunately, even when the patient has passed, we still have fire rescue there. We've now, on known fentanyl cases, when we get there and somebody says this is what it is, or we have evidence that's what it is, it's now kind of a biohazard scene. We've all seen the television things where the officers are on the traffic stops and they're falling out from the minutest amounts of fentanyl. The sheriff's office, we have our behavioral mental health units. We have our nurses on the intake in the jail. They're asking the questions. We have personnel inside the jail that are trying to deal with the addictions. There's vast amount of resources that are being used on this.
And also, you mentioned resource. How about moving towards the recovery side? So someone shows a willingness to seek treatment, seek support, entering a recovery journey. What are some of the assets that you can utilize or reach out to? And again, this is for everybody, but that we can utilize in the county right now.
Well, the sheriff's office, we're a law enforcement business, but we not only are enforcement, but we're also education. There's the 211 hotline. There are numerous local resources that the deputies can reach out to, especially our new behavioral mental health unit. We can reach out to them. They can coordinate with social services, and we can try and get people in there. We're not, the goal of the sheriff, and I don't believe the goal of anyone is to take users and put users in prisons. That doesn't solve the problem. It takes rehabilitation. We have the good faith law where, we're trying not to go after, the family or the friend that calls in and says this issue is there. We're trying to do everything we can from a law enforcement perspective, not to move into a social services type of work, but we're trying to work with our community. These are our citizens, our family, our friends, and we're trying to get them the help that they need. They don't always need to go to prison, but sometimes jail does help. Jail sometimes is the start of a court-ordered rehabilitation. So,
is there an
comment on this?
opportunity? Oh, yeah, go ahead, Chief Kemmel.
In fire rescue, there's been a big push in this last year from administration to start looking at this from a different perspective. Always in the past, it's been intervention only, and there's really three categories. You got intervention, which is what our paramedics do in the field. Somebody has overdosed, we give them Narcan, we intubate them, we help them breathe until they recover, or if they don't recover, we get them to the hospital, and it goes on from there. And that's all we've ever done in the past. Now we're looking at recovery and actually rehabilitation, and as well as prevention. Over the last year, we've started 2 programs through grant-funded programs that will help deal with other sides of this. Number one, there's the CORI program. We started that I believe it was April. CORI stands for Collaborative Opioid Response Initiative, and we're working with Martin County's Health and Human Services, SO with Captain Perez. We're working on putting together some prevention issues with those guys. And we're working with the hospitals trying to establish a way to continue our contact with the patients that we have had that have overdosed, and then doing follow-up services with them to help push them or move them in the direction of rehabilitation, be it through medical assisted treatment or through residential detox, et cetera. And we've really pushed really hard to establish relationships with detox facilities and rehab facilities to help donate some of this room, a bed, to help us get the patients that we have transported help down the line to help move them towards rejoining society and getting away from this. Also, CORI focuses primarily on prevention, doing things like this, what we're doing here today, and educating the population. Also, we're working with the Sheriff's Office, Captain Perez, establishing consultation with our Maria Valls, who is our social worker medical social worker who we were able to hire through the CORI program. And they're going to start working together with people who have been in jail, who are about to be released within 30 to 60 days, to help establish some type of relationship and help them understand where they can go and the resources that are available to them once they get out, as opposed to going right back to the drugs. So it's a multifaceted approach with the CORI program, primarily follow-up and trying to push people to, basically letting people know there are people out there who care, and we're trying to do everything we can to find a pathway for them to get away from these drugs. The other program is our community paramedic program that just started in August 1st. And community paramedics work in a variety of fields, bringing healthcare to people who can't afford it and who need it the most. One of those areas that they're focusing on is working with the CORI program to continue that follow-up and do a lot more work at the hospitals. In fact, next week we have a meeting with Cleveland Clinic to help establish MAT. MAT is the medical assisted treatment at the hospitals and the EDs here in Martin County. I hope he's listening, because Monday I'm not leaving until we actually make progress on this. So, Chris, I hope you're listening. But our meeting is Monday morning, and I'm not leaving until we get plans moving forward and making things happen. But
So first of all,
making inroads.
you're definitely making inroads, and it sounds that everybody's solution focused here in Martin County. We're not approaching this as a reaction, but a response to an issue. And you mentioned something very important too. In this fight, in many other places, medically assisted treatment or medication assisted treatment strategies. And I'll certainly bring Dr. J on this. Is people have a lot of questions. What does that mean, right? Because it's kind of bandied about sometimes as MAT, and those in the know what it is and knows the effectiveness that can have in a treatment program. But Dr. Kuchera, could you explain some of the key components to MAT, or some of those medications that people may be hearing about, and how those can be effectively administered?
Sure, but first I wanted to kind of confuse things and muddy the water, because there's been a shift in the scientific approach to medications for the treatment of opioid disorder. So it used to be called medication-assisted treatment, and this is a lot of this guidance and scientific wisdom has come out of places like SAMHSA, the Substance Abuse Mental Health Services Administration, and their groups. And so the idea was that to treat an opioid disorder, which is addiction, I called it opioid disorder, is to have behavioral supports like therapies and community supports, and that's I believe that's very important. But there is a group of very well-informed and very hardworking scientists, clinical scientists, that have been studying outcomes and effects of medications, and it is a bit difficult. There's a conflict now. There's a group that very fervently argues that all you have to do is just get the individual the buprenorphine, let that molecule sit in their brain and decrease the cravings and stabilize them. And I know several people, friends of mine, who have been on buprenorphine. It's been life-saving. It's really restored their life. But then there's the group that thinks that buprenorphine really doesn't work unless it's combined with really good, strong behavioral supports, community-based programs, peer programs, and whatnot. And then there's the group that thinks that buprenorphine and methadone really should be avoided, and they're shamed and vilified. And that's like a lot of the NA groups, Narcotics Anonymous around here, still feels that way. I've had a lot of dialogue with Narcotics Anonymous World Headquarters outside of Van Nuys. Met with them. But it varies. It's such a kind of confusing mishmash, but the idea is no one way works for everybody. And every person goes through phases in their walk in addiction where sometimes they're ready for medications. They really need that medication. Other places like Celebrate Recovery, that's very strongly faith-based, or NA, that's faith-based, they truly believe that, abstinence is the gold standard. Certainly, to live completely drug-free is pie in the sky. That is the gold standard. But there's individuals where the brain has been programmed by long-term exposure to high doses. I mean, if you think when you're injecting heroin, you really are giving the brain large doses of opioid, larger than what you would get from a doctor for pain. And that reprogramming can become very problematic. So I kind of say it would be like if I said, Micah, I want you to stay awake for 4 days in a row.
Well, I do have a 2.5-year-old, so I'm well versed.
Well, okay, well, 8 days. So, it's like your brain just gets to the point where it can't do it. And some people say, well, it's just an excuse or whatever, but, it is very, very difficult. I don't know. I haven't had an opioid use disorder, but so the medications are incredibly important. And to further confuse things, there's the two medicines, methadone and buprenorphine, that act like heroin or like oxycodone or the opioid. They mimic it in the brain, but they stick around a lot longer, and they seem to smooth things out. They're not so abusable, and they have definite good effects. Then there's the opposite, which is a relative of naloxone that we use to spray, and it's called naltrexone or Vivitrol. And so naltrexone is a blocker. That is the third of the 3 medications that are used in the United States to treat opioid use disorder. So MAT is now called MOUD in higher circles. You can still call it MAT. A lot of clinicians, a lot of medical people still say MAT. But they rebranded it as medications for opioid use disorder to try and detach it from the association between giving the drug, like here, take this medicine, and then just go about your business, and giving the drug and combining it with behavioral therapies. So changing the term has changed the implication for how the drug is used in a person's recovery, and it detaches it from the behavioral supports, which to me, again, I think are critical. It works both ways. I actually don't want to start, if people are listening right now that are all about just MOUD alone, the people are very passionate about this. I know people in recovery, they came to one of our, she drove from over on the West Coast. She said, just, forget about 12 steps and stuff. Just get them, the buprenorphine, or get them the medicine or whatever, It's like, and these are coming from people that have had strong addictions and stuff. Anyway.
And Dr. Kuchera, you're talking about that detachment and sort of rebranding it. It also makes it seem a little more accessible, not so much accessible to physically get it, but also as an awareness and as an understanding of a community. This is a tool. This is something that can be used as a bridge. And one of those issues we deal with in substance use disorder, certainly mental health disorder, is the stigma of the disease and how that can be a barrier to that. And so I certainly wanted to, and this, again, questions for everyone, but I wanted to direct this towards Dr. Marshall and certainly Robin. For those that, how do you encourage people to seek help when the stigma has been so contrary that, and Robin, you talked about this. This is, this is a disease. This is something's wrong with this individual, and that just isn't the case. How do you encourage people to seek help when they need it? Dr. Marshall, you want to?
Before I go into that, I just want to piggyback what the doctor was saying a little bit. The game has changed when it comes to drugs these days, where, yes, abstinence is, would absolutely be the goal, but even in the behavioral health field, we have moved more towards risk reduction support. So, a lot of people have misconceptions about MAT, and going back to what was said previously, addiction is a very, very complex disease. The addiction itself, the brain structure changes. So you might want to consider the idea that, for a person that's depressed, that their brain structure might allow for them to be more apt to be depressed, and that individual ends up using psychotropics and are much better. Coupled with therapy, they're doing well. This can be a similar type of dynamic where the brain structure is different now. So with MIT support as well as with therapy, a person can be very successful in treatment. So I just wanted to make sure to put that out there as to what kind of the dynamic has been from the behavioral health side of MAT. With regards to stigma, that's a very difficult question to answer. Ultimately, individuals with whether it be mental health diagnoses or addiction diagnoses that are in treatment or seeking treatment are protected by the laws of our country with the American with Disabilities Act. However, at the end of the day, that doesn't mean that stigma is not going to occur. When it comes to seeking treatment and, having that conversation, I like to believe, or I do believe, that any action that you take is going to come with positive consequences and negative consequences. The road to recovery is going to come with positive consequences and negative consequences. An individual that is concerned about the stigma, I would probably invite them to have a conversation with an impartial individual, whether that be a peer advocate, which I guess we can talk a little bit about later, a mental health practitioner, individual from the substance abuse hotline, and having and being able to process that, because that is real. I mean, I can't tell someone, oh, don't worry about it, of course, because that's going to be their experiences, and they may experience some of that negativity.
And Robin, as a family, were these some of these pressures that you were observing or feeling going through this process?
I guess I'd like to speak to that almost as a whole.
Sure.
Because I am boots on the ground out there almost every single day, not so much now in the pandemic, but definitely on the phone, and I am still out there. Not affiliated with any kind of treatment center, but I'm advocating and helping mostly those that are uninsured, brokered, or homeless. And what I'm seeing out there and have seen for years, and especially now with MAT coming in, it is definitely, there is a place out here for this. But it's only a piece. And I think that's something that one of the things, like it down south, there's now the hospital that's working the stabilization unit, and the goal is to get them right onto MAT. It's not going to work for everybody. Not everybody wants to be on MAT, and that's something that we need to, again, it's continuing to educate and let them know that there are multiple options out there. And we need to make sure that it's not just putting them on just MAT. As the doctor said, we need to make sure that there's counseling involved and a support system. And where these kids are getting, and I'm sorry I call everybody kids, where they're getting judged are their sober communities. Those are the people that are coming down on them. They don't feel like that they can go in and work 12 steps because now I'm on MAT. I need to lie about it, or I need to keep it a secret. It becomes a problem because their peers are the ones that are now saying you're not staying clean. And this happens every single day. This is what we're seeing. And yes, and so again, we're trying to educate people to say this is what we're keeping people alive. And help them to understand that 12-step or abstinent base is not for everybody. So again, it's an evolving thing as we're all going forward.
And I wanted to, first of all, the entire panel, I hope people at home are understanding this too. One of the things that I commend all of you on is you keep speaking of the individual. This is an individualized issue, and that everyone here values the experience of the individual, and that not one path, one method is going to work for all, or one time, or, I mean, this is it's a disease of management, not a disease of fix, right? We've heard that this is it's not a law enforcement issue. That's not going to get your way out of this. A strict medication is not going to, one behavioral approach is not going to be. It's how do we treat the individual, and I think that that's very important for people to understand out in the community. But I wanted a couple quickly. First of all, I wanted to honor some of the questions that have come through on Facebook, and these go hand in hand with what's happening here, because earlier on we discussed the use of naloxone, Narcan, if you will, and reversal drugs, and this is something that's utilized effectively here in Martin County. And a question that came through is, how would you recommend or what would you say to other law enforcement agencies that may be resistant or to carrying that? Are there some suggestions that you would offer to them that may encourage them to be utilizing this product?
You know, as you're asking me that, I'm sitting there thinking, in our evidence processing room, we have Narcan. You know, you should carry it for yourself. You should carry it for your fellow man. You should carry it for that child that touched something that he didn't know what it was. This isn't about, I don't want to help an addict, or the addict put himself in this. This is about helping your fellow man. You should carry it because it's the right thing to do.
A life is a life.
Yeah, and this is a sort of a technical question too. Back in the day, shall we say? I mean, this is such a short-lived thing, but even 4 or 5 years ago, to get Narcan and naloxone was a bit of a struggle, if you will. And certain suppliers would give it, or pharmaceutical companies would donate it. It might have been expired, but it still would work. Is there a process to get even expired Narcan to the public, or other ways to get public access to it that once it's either not in use or available?
That's
a
something
question
I'm
that
working
came
on right now. I'm working on distributing Narcan out to some of the public, especially if we go to a call in which there's an OD, to when our community paramedic goes out to get Narcan to those people. So we know there's already an issue if they won't get rehab or treatment or check themselves in or work with us. Maybe at least we can help get them a head start before the overdose is the last overdose.
Yeah.
We're working on that. It's not easy. And I can't support using expired medications and give them out. There's no way I can get away with that.
Well, we also have a much greater access to the product now than we once did.
Oh, absolutely,
As
yeah.
well. So it's a bit
I
ridiculous.
believe you can get it at Walgreens.
Yes.
Or CVS.
And if I'm not mistaken, Dr. Chair, there's a standing order from the Surgeon General from.
There's a
State of
standing
Florida.
order by the Florida Physician General, Surgeon General, so you should be able to get it at any pharmacy under the standing order. And there's also the Florida Statute 381.887, which is the naloxone. It's the emergency opioid antagonist law or whatever it is, the naloxone law, and basically that statute specifically was designed to put naloxone into the hands of everybody and reduce the fear of repercussion if you use it. If you look at it, it says the law is intended to promote the distribution and use of naloxone. It's a Florida statute. So there's positive, supportive law in place right now specifically to make sure that the naloxone gets into the community. We really are making it easy. But, I talked to the pharmacies a year or two into the standing order, and they said that just people aren't coming in. And, I don't know, maybe it's a sense of hopelessness. Like if you go get the Narcan, then you're saying, you're kind of resigning, or maybe it's stigma or embarrassment or whatever it is. I don't know.
Well, let's talk about speaking of advocacy, Robin, can you talk about some of the advocacy components of that as well?
So we give out Narcan every day. I mean, we put it in blessing bags. We're handing it to the homeless. We're making sure sober homes have it. If young men or women that we follow are saying they don't have it in their sober homes, we make sure that the sober homes have it. My husband, I make sure that all of his vehicles have it. He's a plumbing contractor. I mean, people just need to be educated, as you're saying, but there is, again, that fear of and I've heard this from other family members, that if I acknowledge that I might need to bring this into my house, then I'm acknowledging that there's a problem within my home. And unfortunately, it's just having to educate them to say that this can keep your child alive versus not having in. I mean, the other day, I was part of, giving somebody 3 doses, and that young man would have died if we weren't there. So it's absolutely vital to, educate and make sure people know that this is something that's available, that they can go to the pharmacist. They can go to various places, Rebel Recovery down in West Palm Beach. There's going to be the hub. We'll be teaching them how to be able to administer, and that it's very simple and is the difference between being alive and dead.
And Robin, you mentioned some very important community partners in this. And of course, we've heard from public safety and law enforcement, which, so we're seeing leadership at the top working very hard on this issue. We're also seeing the grassroots community efforts here.
Yep.
So top up, bottom up as well, and certainly the medical community as well, working in concert. We know that that's a critical element to this. But you mentioned specifically an entity, which I'll speak personally, I'm very connected to as well, but the hub, which is Palm Beach, which is considered a recovery community center and a recovery community organization. Can you describe a little bit of that entity? as a possible solution for something we could enable here in Martin County as well.
So what the Recovery Community Center is going to be is that extension piece. As many of us know, detox treatment alone are not going to be the answer. You need to, the place where people fall down over and over again is, we come out, they go into a sober living, there's this expectation, I'm going to get a job in a week or two. If I don't get that job, I might get bounced out. There's enormous stress going on. These kids have barely, their brains haven't even started to calm down yet. And now they're thrown into having to start living life again on life's terms, and they have no idea how to do that. I mean, again, I'll put my son in, for example. We were a supportive family. We were somebody that was part of his recovery. And he still, he didn't work a steady job. So you've got kids out there that haven't worked jobs, that don't know how to do a resume, that don't even know how to interview, that don't know how to take care of legal issues. Where do I go to do this? How do I do this? How do I get a license again? So those are the pieces that we are putting together at the Recovery Community Center, that extension piece that, people can come in, feel comfortable, not judged, and ask for the things that they need to start putting their lives back together.
And then what is the grand cost of those services?
I'm sorry?
What is the cost of those services?
Free. Free.
And creating that
Anybody
environment,
can
right?
come in.
This is hard to believe. We're actually almost out of time. As you can tell, this conversation is a big conversation. Certainly the goal would be to have many more like this. Before I kind of move to a final question for all of you, I just wanted to thank each and every one of you. I hope the community understands that this community is looking at this, even though it may be described as a crisis, we look at it more as a challenge. And what opportunities do we have here now to help the citizens of Martin County? So I can't thank you all enough and the work you do. But I'd like to move this last piece. Two things. For those that are listening on Facebook Live, we've created a little survey at the end, so just a little 3-question survey. So please, collecting information from the community is very important. It helps us do our work and inform the work that we can do. So if you could take that survey, we'd really appreciate that. And then finally, as we're moving into the solution-focused approach, many resources available. Coordinating those resources is going to be critical. But each of you in your unique perspectives, if there was one element that we could add to this solution, what would it be, and how do you feel we could best implement that component? And I'll start with, we're going to do around the horn, if you will. I'll start with Dr. Marshall, perhaps on the behavioral side.
Sure, and I actually talk about this quite frequently because I feel like this is an issue throughout Florida, is the access to quality mental health services at various levels, whether that's outpatient, partial, inpatient to full, long-term inpatient. Unless an individual has very good coverage or very good financial resources, it is very difficult for them to get connected to that kind of good quality treatment. That would be my hope.
I would have probably said that myself, but if I were to go, I'm going to say, keeping lines of communication open, I think, again, we always say that we're communicating and that things are open and we're out here, but I want people to hear, if they're hearing anything in this, is that you're not alone. If you're a family member, if you're the person that's suffering and struggling, you're not alone. This does affect, doesn't matter, color, age, race, financial, this affects everybody in this country right now in one way, shape, or form. Maybe it hasn't touched you yet, but it will touch you. So please hear that you're not alone, that don't be ashamed to ask for help or to reach out, because that can make the difference.
Chief Campbell.
From my perspective, within my field, I think it's follow-up is the biggest thing. If we had more caseworkers like Maria Vaus, like Michelle Miller, who work so tirelessly to help other people, if we had more people like that and not stopping with their follow-up, making sure people know that there are people who care out there, and there is a path. It might be a convoluted path, and we're working on it, but there is a path and people care.
Thank you.
Well, I'd also like to say the comment I made about Narcotics Anonymous and MAT, I understand completely from my friends who are in 12 steps. These people have almost, they've come close to losing their lives and everything, and it's just been tragic. And for them, they view MAT as threatening. So people are, everybody, the people that struggle with addiction and the families and the loved ones, this is a very deep and potentially terrifying and hurtful and scary kind of experience. And I would hope that everybody would start by their own personal, cultivation and to find ways to inspire their own compassion and hope and their own, spiritual connections, and then share that with each other so that everyone is going through recovery, whether or not you've got the addiction or you're a parent or whatever you are. But I would think that I can't have, you guys are awesome, but I have to do my own work. So the thing I would hope for is that everyone has their spiritual experience and really keeps hope and compassion alive and acceptance, because it's very terrifying, and that has a tendency to really create some problems when people get so scared that they're very anti buprenorphine, or they're very pro whatever. So just our own personal walk with everyone listening.
You look around the room, there's not one of us in here that can do this by ourselves. We truly can't. Law enforcement can't do it. Fire rescue can't do it. It takes cooperation, and it takes communication. One of the things we have to let the families and the friends and the people that are involved, they have to know this isn't going to go away. A wish and a hope is not going to solve this. Soft approach doesn't always work. You have to stay involved. You have to follow through with the steps. It's been said you have to repeat those steps. But just saying, hey, it happened, he's going to get better, doesn't work. It takes a community to solve this problem. I can't do it alone. Chief can't do it alone. Neither one of the doctors or Ms. Robin can do this by herself.
And each of you bring that unique perspective, and I like that every single one of you talked about the understanding that this is a together. This is a we issue. This is not an I issue. And I think as we sum up here this evening, a couple key things. One, I see this as a call to action. And obviously everyone, as Dr. Chair said, everybody has their work that they're doing, but we have to have these dialogues. We have to work together on this. One way that the community could get involved and consider this an invitation, we do have a Drug and Alcohol Advisory Committee here in Martin County. It's a long-standing committee. The next meeting, I'm telling you, we're getting specific here, but Tuesday, September 9th at 3:30, and that's over at the County Commissioner's office. Please come. Please get involved. I wanted to discuss this with everybody here too, is that what we're talking about at the grassroots level to the county level is that these are protective factors that we believe in for our community, right? People have families, people have businesses, people come to Martin County because it's a great place to live. They don't want to tune in and say, what do you mean in a crisis? As we're all wearing masks and are 9 feet apart and we're looking at an epidemic within a pandemic. There's a lot of stressors out there right now. And from every element and from every ailment and from every challenge, looking at this as a solution-based community, I think is very critical. So as we close tonight, again, I want to thank each and every one of you for the work that you do, and an invitation to our community here in Martin County to look not only within but also without. So some of those great solutions that are out there, know that there are people that care, know that there's a lot of expertise, and that we're all in this together. So for everybody that joined us tonight, thank you for up here on the panel, and for certainly those that were watching at home. We hope that this isn't a one-off event. We hope that this dialogue continues. Actually, I encourage it. I think we all encourage it. We all need to communicate and be in this together. So thank you all very much this evening for everything that you do and for joining us. Thank you.